Sure. So I'll be straight. Nobody likes a requirement, right? The good news is needs assessments are actually quite useful. So let's go ahead and start with the foundation and understanding what's expected and required by HRSA to meet the expectation around needs assessment. So first, I want to start with a screenshot that shows you what the compliance manual looks like. If this is new language for you, don't worry. There's links to this resource. It's publicly available. And there are two companion documents, both available electronically. This one is the compliance manual, and the adjoining document is called the Site Visit Protocol, or SVP. Both of them have chapters that are broken out based on the authorizing statute for the health center program. Why am I giving you all of this background? It's because if you think about it, the health center program was founded over 65 years ago in this authorizing piece of legislation from Congress, and Congress made the intention of requiring every organization that wanted to be called a health center, funded or lookalike, to do a needs assessment. It was baked into this cake long, long ago for a very specific reason. And that was that these health centers, regardless of whether they're rural, urban, frontier, if they're large or small, needed to be responsive in their missions to the community that they're serving. That's why every health center is so incredibly unique. So let's talk about what HRSA expects when they're talking about their needs assessment. There's two major areas, and under these, what they call chapters, like you see on this screen, on the next screen, I'm going to show you how this is broken out into elements. So for the program requirement, element A, there are two components that you need to focus on. First, I want to talk about frequency. Element A needs to be done annually. This differs from element B, okay? So the government rules are a little confusing, so that's why I want to break this out and give you visuals so you can go back to the slides and track this as you need to. So under element A, the two things you need to be doing are looking at the actual zip codes of where your patients are coming from. This is called patient origin data. It comes from UDS, Uniform Data System. Lots of acronyms. I understand. I'm sorry. But there is an acronym tool. Ted, I'll let Ted talk about that later if you need it, if you're new to the health center family. So what HRSA is expecting is an analysis of the most common places that patients are coming from, broken down by zip code. I'm going to show you on the next screen what I recommend in terms of how you organize doing this work and then putting it into your board minutes so that you can get credit for meeting this requirement. But the second step is to then do a pull out of your Form 5B, another government acronym. That's your scope of project in terms of your sites, and confirm that what you have defined in your application to become a health center funded or lookalike, part of that application includes this Form 5B. It is the definition of all of your physical addresses. If you have a mobile clinic, that's on there as well. And then what all the service target populations are by zip code. So what HRSA is looking for is in that Form 5B, these are the people you say you're serving. This is the area, your service area. And what you're pulling out of your UDS in zip code and ranked is who you're serving. And what they're looking for is, do they jive? And so I've got a screenshot here of two examples. I've just put in A through F as fake zip codes. But what I like to recommend folks to do is sort their data into Excel if you've got that capability, and just do a descending sort. It does the math for you. But you're looking at where your patients are coming from and doing a cumulative percentage. So here on the left of your screen, you'll see that in this example, 78% of the patients are coming from just 6 zip codes. That may or may not be reflective of your service area. If you're serving a more sparsely populated area, you may actually have a lot of zip codes, and that's fine. What you're doing next is on the right side of the screen, you're seeing that's a screenshot of a Form 5B. It's actually more extensive. There's more to that form, but there's an area where you've listed your zip codes. So you want to make sure that the organization that where you say you're serving still matches your population. And it may seem pretty obvious that this is happening in your organization, but I want to explain why this is so relevant. Not only am I a reviewer, as was mentioned in my intro, but having been in the health center world for a really long time, I've had a chance to see some pretty unique situations. In Arizona, for example, there was an airport expansion, and a health center was located in a residential area. It was like literally a neighborhood health center. That entire area of land was being acquired by the airport for an airport expansion. So what happened is the residents started to sell their homes because they had a good deal, and they had to leave, unfortunately. So patients started moving, but the health center was still physically located where it had always been until it found a new location. So there was a moment in time where the health center's physical zip code that it was trying to reach and where the population weren't actually matching. If I could give an example from today, when I think about the impacts of um, extreme weather, like fires or flooding, there may be situations where population is in flux. And so what you set out as your zip codes may actually look different from where your patients are coming from. So there's purpose behind this requirement, and it is a helpful way to just ground the work you're doing and making sure that authentically you're serving who you set out to serve. So I want to switch gears now and talk about the next element in this requirement. And this one has a different frequency, as I mentioned, and it is to be done every 3 years. So you have a lot more time to get to this one. And this may be the requirement you're thinking of when you decided to join today's webinar, which is what we call a needs assessment or community needs assessment, lots of different acronyms again there. But it needs to be done once every 3 years. And the results must be used for the purpose of informing and improving the delivery of services. So that was in the definition that we shared earlier today, and there's a reason for it, as was mentioned, and that is that it comes directly out of this requirement. So let's dive into the pieces here. Again, every word that comes out of this requirement is part of the assessment. So this is not a conceptual idea where you can kind of interpret it yourself. I highly recommend you just follow the words as they've been provided here from the compliance manual and site visit protocol. So in that once every 3 years community needs assessment, you want to be sure that it includes, whether you're doing it yourself or you're working with a consultant or partners or blend. I know that all of those categories are represented today in our participants. You want to make sure that the factors associated with access to care and healthcare utilization are included. So if your needs assessment only includes data on prevalence and incidence of health conditions, it would not be satisfactory for the requirement. You need to know what's happening with patients in terms of access to services, if there are barriers to access to services, and the utilization of services. But that's not enough. You also need to have the top causes of morbidity and mortality in there. And then lastly, you must have other unique characteristics of patients that impact their access to healthcare. So all three of those, what I like to see as a reviewer is if the needs assessment even has those sections or it's highlighted or there's a summary that shows that all three of those elements are included in the community needs assessment. And then the last visual I want to provide in this discussion is just a deep dive on something I emphasized verbally as I was introducing this concept of element B. And that is in the site visit protocol, there is a specific question on the next slide. You'll see what it looks like. And it is verbatim. Did the health center provide at least one example of how it utilized the results of its needs assessment to inform and improve the delivery of services? So just like satisfying any of the requirements in the compliance manual, it can be complicated, and you can get so close. You can do that annual review that I talked about with the zip codes and your Form 5B, awesome. You can also do this comprehensive once every 3 years needs assessment that looks at the factors to access to care utilization, morbidity and mortality, as well as unique characteristics, also fantastic, but you're not done. The last question in that section can get folks hung up, and so I want you to be ready for it, which is you can't just do these things and say you did it and you submit it with your application and that's the end of it. The requirement from Congress was always rooted in the concept that you're using this data. You're using this data to inform the activities or improve the work in the delivery of services. So I can give some examples. You know, if your needs assessment talks about transportation barriers for a specific population, is this something that the executive team and the board are looking at and then creating a response to that transportation need? And it could look like anything you want it to. This is where HRSA doesn't tell you how to respond. That's up to the health center. So you could provide transportation services yourself. You could have a mobile unit that goes to the community if there's, you know, a lot of barriers and it makes business sense for you. Or you could use telehealth, right? And there's probably even more. There's lots and lots of ways to respond to the need. What's most important is that I want you to be ready for this question and have it documented. So the last slide here as a tip from a compliance reviewer, I've got 3 major tips for you. First, plan, take credit for your work, document what you're doing, how you're using your needs assessment, that you're sharing your needs assessment with the board, really linking the fact that this was done with the sharing of that information, and then informing. And those decisions can be anything. You could be informing personnel policies, you could be informing budget, you could be informing lots of things, but make sure you take credit for that. Next, you want to be sure that you're keeping up with monitoring. So if you learned that transportation was a barrier, you want to be sure that after you've signed a contract for transportation services, that is meeting the need. Sometimes we spend money in the health center world, or we create an intervention in the health center space, and we don't always know if it is or isn't working. What if what we offered didn't actually meet the need? So really important that you create tools and reporting to keep yourself honest and accountable. And then lastly, I really suggest planning a workflow strategically in the compliance space. So today we're talking about needs assessments, but there is a way to use your needs assessment to support strategic planning, which is another HRSA compliance requirement that in fact can support your budget planning, another HRSA requirement. And all of that really highlights where the organization's going, what you're setting out to do, which can be used for CEO oversight and evaluation. So that's the sweet spot. It's the ideal. Organizations sometimes have their budget cycles on a different cycle from their strategic planning. So sometimes it's not perfect. You start where you start, but if you can get into a flow where things are linking up, it does make things a whole lot easier.
So what types of tools and data can be used in a needs assessment? You'll see in the NAC Quick Guide that we have links to many, and I can highlight a few here. For demographics or socioeconomics, one of the most common data sources is the American Community Survey, or ACS. This is from the US Census Bureau, and it has metrics like race, ethnicity, income, unemployment, and language spoken, and it's broken out by zip code, municipality, and county for the whole US. For some of our social drivers of health data, like on housing, food, or transportation, you will find that there are some screening tools like Prepare or Health Leads that you can use to get at these types of needs. Some of these indicators are also available from the ACS or from mapping tools like Policy Map. For health behavior indicators, the Behavioral Risk Factor Surveillance System, also known as BRFIS, is a wonderful, rigorous phone survey that the CDC has been running for decades. It's a great tool for understanding things like use of preventive screenings, alcohol use, dietary habits, exercise, and more. You can find BRFIS data mapped onto different geographies by using the mapping tool CDC Places. To get data on health access and utilization, UDS Mapper is one of the common sources that you'll see. It has data about insurance as well as patients served and unserved by health centers. This is also an area in terms of health access and utilization where some health centers may choose to incorporate their own key performance data about their own visits, their sliding fee scale utilization, or payer mix. To understand health conditions and disparities in the community, we can again use BRFIS data or CDC Places, and we can also use CDC Wonder, which is a great resource for mortality data specifically. Many health centers also rely on their state health departments, cancer registries or vital statistics for morbidity and mortality data. Finally, your needs assessment should really tell the story of your unique community, the unique needs that may differ from other communities, whether that's community violence, environmental health needs, or cultural or religious needs. There may be published literature or needs assessments from other local agencies in your community that speak to these needs, or you might find out about these needs through those qualitative methods, through speaking with members of the community and really learning from them. So there are many different ways to conduct a needs assessment, and as long as you're covering the information laid out in the HRSA program requirement, HRSA actually allows for considerable flexibility in the exact methods and the exact tools and data sources that you use to gather that information. The NAC Quick Guide to Conducting Your Health Center's Needs Assessment has some nice summaries of the many different methods and tools that health centers use, and I want to do just a quick tour of a few of them now. In particular, health centers are encouraged to consider taking a mixed methods approach to needs assessment, which means not just using quantitative methods, which focus on numerical data, and they're what most people think of when they think of data, but also blending those with qualitative methods, which focus more on themes or perspectives. So, what are some of the main quantitative methods that you can use in a needs assessment? One option is primary source data, like your health center's own UDS or EMR data, which can help you understand your own patient demographics, your quality performance, or appointment patterns. Be mindful, though, that this data is only on your patients and it isn't on the broader community at large, so it may not reflect the needs of those who are not currently being served by your health center. Most health centers will therefore also use secondary source data like census data, CDC, and health department data, which helps with understanding overall community demographics, socioeconomics, and health outcomes. When using secondary source data, it's important to consider how recent it is and also what geography it is for, since you would ideally want it to be for your specific service area or target population, your specific zip codes. And if it isn't for that, you might have to use some extrapolation techniques or analysis in order to have estimates of this data for your particular community. You can also get quantitative data from other published literature or other organizations' needs assessments that relate to your particular populations or communities. So, for example, if your health center serves a special population like migratory or seasonal agricultural workers or people experiencing homelessness, there might be published research or needs assessments about those specific groups that you would want to cite, especially since those groups may not always be as visible in other sources of data. There are also a number of qualitative methods you might use, focusing more on themes rather than on numbers. One method is surveys of patients or community members, which can help generate perspectives from people about their own lived experiences, accessing care, and with health and social needs in the community. There are some surveys that are more quantitative in nature, but the types of patient satisfaction surveys or community perspective surveys or surveys of that nature that most health centers do, those are often considered to be really qualitative in nature because they focus on themes and perspectives. It's important to make sure that even if you're not aiming for statistical significance or a perfectly weighted group of respondents or, sort of an academic level of a survey, that you at least make sure you're getting a decent number and mix of respondents and that you're incorporating strategies to make the survey accessible to the people that you want to respond. And you're trying to get good participation from those harder to reach populations in your community. Interviews are another great qualitative method, and these are usually one-on-one conversations, which can be a great way to learn from subject matter experts like community leaders or elected officials or other people with sort of unique perspectives about what they think is happening in the community or what is needed in the community. You can also use interviews to help validate or clarify information that you're seeing in other methods, but do keep in mind that each interview subject is just one perspective. To hear from more than one perspective at once, focus groups are a really great method. These bring together groups of peers, such as a group of frontline staff or of patients or of like community members, to have a dialogue together. And they can be great for gathering information from people who have grassroots knowledge of the community. Focus groups require a lot of careful planning to make sure that they're well facilitated by someone that the group will feel comfortable speaking with and that they're a safe space for people to all talk together. Okay, so once you've completed all the data gathering for your needs assessment and synthesized the results or findings, how do you actually structure and share your needs assessment report? Needs assessments are typically structured into a standalone written document with a table of contents that can look roughly like this. It usually starts with a 1 to 2 page executive summary, which covers the highlights of your findings and any conclusions or recommendations. Even though the executive summary comes first in a report, One pro tip that I want to share is to actually write the executive summary last so that you really know what all the most meaningful parts of the report are before writing it. One of the benefits of having an executive summary is that it's short and easily digestible. So there's a better chance that your busy partners, your board members, staff members, funders, whomever you might want to ultimately share the report with will actually read the whole executive summary. Next is an introduction that spells out the purpose of the assessment, outlines the methods and sources that were used, defines the service area, and lays out any organizational framework for the document. One commonly used organizational framework is the 5 social determinants of health areas from Healthy People 2030, which you can see listed here. Using this framework provides a structured way to organize and present mixed methods findings about the service area population and community. You can, for example, include information you learn about income and unemployment under the category economic stability. And you can include housing, homelessness, transportation, and food deserts under neighborhood and built environment. You will also want to have a section on morbidity and mortality and health disparities data in the community, often organized around topics like chronic diseases, cancer, maternal child health, behavioral health, infectious diseases, and other conditions. This is a health center program requirement, so do not forget to include morbidity, mortality, and health disparities data. Most needs assessments also include some information about the overall healthcare environment or context or landscape to cover things like changes in policy or the funding environment or other things that are affecting health systematically in the service area. Some health centers may also want to include other sections in their needs assessment. Some health centers have a section that looks at clinical quality or performance data, their own internal quality data, and how that compares to other health centers or to the community need at large. Other health centers may have mini profiles of smaller regions of their community that are served by different sites. There's a lot of flexibility that HRSA allows in terms of other topics that you might include in a needs assessment. Finally, ending with a conclusion helps the reader by summarizing the whole report. And ideally, the conclusion also includes a few next steps and recommendations. These don't necessarily have to be complex or expensive recommendations. They could just be things to explore in a future strategic plan, partnerships to deepen, or recommendations for adjusting the board composition to better reflect the community. It is a best practice to have some possible next steps or recommendations identified in your conclusion. Once you have your report, you will want to share it, right? At a minimum, you will need to share your report with your board so that they can review and approve it and ultimately use those findings in the future to inform and improve the delivery of health center services. There are lots of ways you can share it with the board, including printed or electronic copies, but you can also consider having a presentation at a board meeting or a retreat or something else interactive to get the board more engaged in the findings and to provide an opportunity for discussion. You might also consider sharing the findings with all of your staff. Some health centers choose to present about the needs assessment at an all staff meeting to make sure that staff at every level of the organization are familiar with the community needs. This can be a great professional development activity. It can often be quite interesting for staff that aren't always in strategic conversations. And it can be motivating and a way to connect staff back to the mission and to why they do what they do. You might also consider sharing your needs assessment externally, including with those who participated in the process, key community partners, funders, even the general public. You could post your executive summary or the whole report on your website. You could host a community town hall or a webinar about the findings, or just reach out directly and individually to those who participated in interviews and focus groups to share the findings. This is a really great way to promote equity by circling back with those who contributed to the assessment and make sure they know their contributions were valuable. You can also use the report to start a conversation with your funders, donors, elected officials, organizational partners, or others about the community needs and the opportunities to address them.